I told you the way we treat sepsis has just fundamentally changed, and that one wrong decision in the first hour can literally decide life or death. Stay with me because we're about to break down the brand new 2026 Surviving Sepsis Campaign guidelines into simple, high-yield, ICU-ready concepts you can actually use. This is one of the most important updates in critical care, so let's get into it.
Look, sepsis is a massive killer, and we all know that getting it right early is everything. But these new guidelines, they're not just a little tweak. They represent a huge shift away from rigid protocols and toward what you might call precision medicine. So here's our game plan. We'll cover the new rules for spotting sepsis, the game-changing stratified attack in hour 1, how we stabilize patients, the smartest adjunctive therapies, a new focus on what happens after survival, and then we'll wrap it all up with some rapid-fire takeaways. Let's do this.
All right, let's kick things off with Section 1, the new rules of recognition. This is the first and, you could argue, the most crucial step. Get this right, and everything else falls into place.
For years, we've all been leaning on one particular tool at the bedside. But, the data started rolling in, and it became pretty clear it just wasn't sensitive enough. We were missing people. So, if the old way is out the window, what are we supposed to be doing now?
And here is the big answer. QSOFA as a standalone screening tool is officially out. The guidelines are now strongly against using it by itself. Why? Because it just misses too many patients. So what's in? Well, we're now encouraged to use more sensitive tools like NEWS, NEWS2, MUSE, and yes, even the classic SIRS criteria. The bottom line is we need a wider net.
Now, it's not just about what tool we use. It's also about how and where. And this is a really cool shift. The search for sepsis is now expanding beyond the hospital doors. We're talking about screening in the pre-hospital setting. Yup, in the ambulance. Then, once they arrive, the idea is to have systems in place like a code sepsis or a sepsis huddle. Think of it like a code stroke. A patient hits the criteria, an alarm goes off, and a dedicated team instantly assembles. It's all about speed and getting everyone on the same page, fast.
Okay, if you take away just one thing from this entire explainer, please let it be this. Sepsis is a clinical diagnosis. Your labs, your lactate, your procalcitonin, they're all just pieces of the puzzle. They are helpful for sure, but they are not the whole story. You cannot let a single number, high or low, rule sepsis in or out. It always comes down to the whole clinical picture and your judgment.
Okay, moving on to Section 2. And folks, this is the big one. This is probably the most significant practice-altering change in the entire 2026 guideline. We are completely reframing how we approach antibiotics.
You know the old mantra, right? Suspect sepsis, give antibiotics within an hour, period. Well, not anymore. We're moving to a much smarter, stratified approach. So here's how it works. If your patient is clearly in septic shock or has a very high probability of sepsis, yes, that 1 hour clock is still ticking. Don't delay. But if sepsis is just possible and the patient is stable, you now have a window of up to 3 hours to investigate before starting those antibiotics. And get this, if the likelihood of infection is low, you can actually defer antibiotics and continue your workup. This is a massive shift.
So, why the big change? It all comes down to balance. We're trying to walk this tightrope. We know that for true septic shock, time is everything. But we also know that carpet bombing every patient with a fever and tachycardia with broad-spectrum antibiotics has serious consequences. We're talking about driving resistance, wrecking the microbiome, all of it. This new approach empowers us to be both urgent when we need to be and responsible when we can be.
All right, we've dealt with identification and infection control. Let's move into Section 3, stabilizing the patient. This is all about hemodynamics, the bread and butter of sepsis resuscitation, fluids and pressors.
So, let's talk fluids. The initial 30 milliliters per kilogram crystalloid bolus. That's still our starting point. No change there. But, and this is a huge but, the real emphasis now is on what happens next. The guideline is basically screaming from the rooftops, reassess, reassess, reassess. The goal is to get away from mindless fluid administration and move towards a dynamic, individualized approach to avoid the very real dangers of fluid overload.
Now, this next point is a game changer for many of us. For years, the dogma has been, wait for the central line before you start pressors. Well, the new guideline is clear. Do not delay. If your patient needs vasopressors to get their blood pressure up, you should start them through a good peripheral IV while you're getting set up for that central line. The time you waste waiting can be incredibly harmful.
So what are we aiming for with those pressors?
let's talk MAP targets. For most of our patients, that magic number is still a MAP of 65 or higher. But the guidelines now add a bit of nuance. For our elderly patients, those over 65, they suggest a target of 60 to 65 might be perfectly acceptable. This could mean less vasopressor exposure for a vulnerable population, often with the same great outcomes.
Okay, Section 4. We've hit the big three: antibiotics, fluids, and pressors. Now let's quickly cover some other crucial supportive therapies. We're just going to hit the highlights here.
Let's run through this rapid fire. First up, steroids. The recommendation is still to use them for patients in septic shock who need vasopressors. Next, glucose control. We're not chasing super tight control anymore. The target is simply less than 180. Blood transfusions, stick with a restrictive strategy. That means we're typically only transfusing if the hemoglobin drops below 7. And finally, nutrition. Use the gut if it works. Start those enteral feeds early.
Of course, sepsis often attacks the lungs, leading to ARDS. If that happens, the principles of lung protective ventilation are absolutely critical. We're talking low tidal volumes, 6 milliliters per kilogram of ideal body weight. And for anyone with moderate to severe ARDS, you have to be thinking about prone positioning and thinking about it early.
All right, let's shift gears to Section 5. This is an area that I'm personally so glad to see getting more and more attention. It's about looking beyond the numbers, beyond just surviving the ICU, and really focusing on the patient's entire journey and their long-term recovery.
A huge part of this is communication. The guidelines are now formally recommending early and repeated goals of care discussions. This isn't a one-and-done conversation. It's about fostering shared decision-making, being honest and clear about prognosis, and really understanding what matters to the patient and their family. Because surviving isn't just about a beating heart. It's about the quality of that survival.
And this is just so vital to understand. For our patients, getting discharged from the hospital is not the finish line. In many ways, it's the start of a whole new marathon. They face a host of long-term challenges, which we now call post-sepsis syndrome. And for the first time, these guidelines really emphasize our responsibility to plan for post-sepsis care.
So what does that long-term recovery focus on? Well, you can think of it as three main pillars. There's the physical rehabilitation, for that profound weakness and deconditioning. There's cognitive rehabilitation, to help with things like brain fog and memory issues. And then, so critically, there's mental health support. We have to be screening for and treating the anxiety, depression, and PTSD that are incredibly common after a life-threatening illness.
Whew, we have covered a lot of ground. So, to make sure all these practice-changing points really stick, let's do a quick, rapid-fire revision of the absolute must-know takeaways.
All right, let's lock this in. Ready? Number 1, for screening, use NEWS or MUSE, not QSOFA. 2, for antibiotics, it's the new 1-hour versus 3-hour stratified strategy. 3, for fluids, give that initial 30 per kilo, then reassess, reassess, reassess. 4, for vasopressors, start them early, and a peripheral line is okay to get going. 5, for MAP targets, aim for 65, but consider 60 to 65 in the elderly. And finally, number 6, always remember, sepsis is a clinical diagnosis.
I want to leave you with this line, because it just perfectly captures the spirit of these guidelines. In sepsis, time is tissue, and the decisions we make, they are our patient's destiny.
So, now that you've got the breakdown, I'm really curious. Which of these changes do you think will have the biggest impact on your daily practice? For me, it has to be the stratified antibiotic strategy. Let me know what you think in the comments below. And hey, if you found this explainer helpful, please do me a favor and hit that like button, share it with your colleagues, and make sure you subscribe for more high-yield, practical content just like this. Thanks for watching.
You